Yes, and I would like to talk about practical sports cardiology, really, and reflect a little bit on the challenges we have as sports cardiologists, and like possibly for many doctors, it's really the sailing a tight course between guidelines but also individualized care. And I know there are a lot of opinions about it. And Paul, you can remain calm. I will not destroy the merit of guidelines. You wouldn't have invited me anyway if I had said I would do this. But I want to reflect critically of what guidelines do and how guidelines work, particularly in a specialty as sports cardiology, which is in some ways, a maverick specialty within sports medicine and the edges. But particularly with guidelines, it's very important because if you allow me to say this, in other specialties, if you follow guidelines, you can do this, you cannot do this. There might be a bit difference in the time of recovery, but when it comes to sports cardiology, this is more. Firstly, this is sudden cardiac death, but it's also a decision about the career of an athlete. Depending on what guidelines you follow, do you follow guidelines, and what else do you have in your arsenal of medical tools and knowledge? Okay, Paul has said all this. I'm enjoying my work here as the chief of or head of cardiology, sports cardiology in Aspetar. We will talk about sudden cardiac death a bit, but not in theory. But you might know this slide or not. This is a very important slide and a very illustrative slide. It's from John Dresner in Seattle. He's one of the leaders in screening. And you can see firstly on the left-hand side there it says Italian athlete age. So this is when the Italians started screening in the 80s. And you can see the sudden cardiac death rate has gone down. This is one of the seminal studies. It has been criticized as well because it is in a very small population in the Veneto region, which has distinct genetic makeups and so on. But you can clearly see a sudden cardiac death rate goes down to below 2 per 100,000. That's what the scale is. If you look at the yellow line, that's John Dresner's and Kim Harmon's data in Minnesota. And you can see also they've screened, and with screening, they reach the same level as the Italians. Very interesting are all the other lines, because if you look at it, these are unscreened athletes, and you can clearly see who's at highest risk. And it's known now for a couple of years as black male college basketball players. They have a highest risk, and their risk for sudden cardiac death is probably 1 in 10,000. And this is higher than having a fatal car accident in the streets of London or Berlin. So this is a real high risk for those, which tells us a lot also, should we change our screening practice in terms of risk sports and so on. But anyway, very important. So we've done a lot of work. There are a lot of guidelines. These are the latest guidelines from 2017 on athlete screening, and they're pretty good. We've got a sensitivity of over 95%. We've got a false positive rate that is less than 5%. So actually fantastic. This is really good. So and I'm using these guidelines daily, and they tell me how to interpret an ECG and when to get suspicious. And they even work in under 16s, because I'll talk a bit about this. Yeah. So this is a study done here by our Aspetar team when Matt Wilson and Nathan Riding and Gavin were here. So if you look at the turquoise figure, this is the false positive rate. If you use the adult guidelines in the kids, is only 7%. So that's good. The sensitivity is not so good if you screen under 16-year-olds. And this is a big problem. And this is a seminal paper, actually, again, we have done, where we looked systematically at all the guidelines, because most of the guidelines, and everyone uses these guidelines for under 16-year-olds. But it's quite clear that these guidelines, they don't hold true. So overall, only 26% of these guidelines, they have actually any real relevance to under 16-year-old athletes. But we all use them for under 16-year-old athletes. So you basically are using a guideline that in 3/4 of all your athletes should not be used, because it has no relevance, which means it didn't even include, when in the writing, data from young kids. So this is the first thing I want to say about guidelines, sports cardiology. We are not quite there yet to have the right guidelines and good guidelines. And of course, I'm really pleased to say that FIFA, particularly Katharina, Andy, and also Andreas, they've listened to it. And for the first time, and Aspetar, we are leading this. I'm beside Aaron Bagish, who's in the center, and Mats Boris and Christian Schmid. I'm one of the chairs of this commission. So we met in Zurich. And for the first time ever, FIFA will produce an under 17, all the ages down, guideline for cardiac screening. worldwide. This is a really brave thing to do, and I have to compliment FIFA Medical to do this, because it's not only getting these experts together and writing these guidelines. We can all do this, we know this, we've got enough experience, but it's also implementing those. And it's not only implementing those at AC Milan or Manchester City or United, it's implementing those all over the world. Are the resources there? Are the strategies there? So we are trying to write a guideline that is scientifically sound, but it's also from a healthcare policy feasible for all the different confederations. And this is also important for Aspetar management. Please listen in here. This is very important to say Aspetar can have a big function here. We are in the position, and geographically, but also from our resources, to really help implement these guidelines worldwide over the next years. They're not written yet. Second guideline, I'm also chairing these, is the new European Society of Cardiology guidelines for cardiac screening in under 16-year-old athletes. So this is, again, a first ever document. So we are really homing in on the youth athletes. And it's great that we are also hosting here in Aspetar the Under 17 World Cup for the next 5 years. So there's a lot of synergy. For the first time, the international organizations produce cardiac screening guidelines. And we have a say in them, because I'm chairing them, and even a third one when we have children with heart disease. And I want to talk about this, because what about athletes with heart disease? It's easy to do all screening the healthy athletes. That is no problem. But what about these athletes who have heart disease, be it youngsters or first team athletes? What do we do with them? So far, often they were absolutely sidelined. Yeah. If you had a cardiac problem, you were out. Yeah. And this will change. This will change. And does it have to be changed? So I've told you now, we've got guidelines. We're producing 3 new guidelines this year. So all happy clappy. Well, one thing is, and this is another big thing, step, which is missing so far, which we are closing this gap now. When do we start screening? And you will find a lot of opinions there, and you all know when we start screening, when they enter Aspire Academy at 12, but, should we do an ECG at 10 years? We've just done a paper with not only sports cardiologists, some of them. Jessica is a fantastic population health specialist. Kim, Flavio, our sports cardiologist. Tim Meyer, is a sports physician with expertise, and I know a little bit about sports cardiology, particularly pediatric sports cardiology. And this paper has just been accepted, and we said 12 years should be the onset. Why is that? If you look at the graph, this is population studies, because from 12 years onwards, the sudden cardiac death rate goes beyond what is a normal population in athletes. That's important. Secondly, many of the diseases, they start showing themselves at 12. And of course, also competition will start at 12 years of age. So this is very, very important to see this. So we say 12 years, and the new guidelines, FIFA or ESC, I'm pretty sure will also incorporate this. So again, are we doing well? And then this is the survey from which I've shown you before, or people know this from before the World Cup, a survey that FIFA sent out to all the team doctors, and 27, as you can see, answered, and they said, what other services do you want from Aspetar and from Qatar during the Football World Cup? And this was the answer. And for half a year, I was very happy about this answer. I thought, oh my God, aren't we important as sports cardiologists? They all want a sports cardiologist. But actually, I'm getting almost a bit more concerned now why this is. I've just shown you we've got guidelines, we've got a network of international experts, and we're screening all these, particularly footballers. Why do these sports physicians want a sports cardiologist there? So firstly, I think it's inherent in the problem, because beyond the screening, there is still a problem. But also, I think, are we as sports cardiologists doing enough? And I think with screening, we probably do. I don't think we should screen more and more often, but are we doing the right things? Yeah. That is for me the question. So the more I think about this graph, the more I think as sports cardiologists have to do something. And why is that? Because these things still happen. You all know Christian Eriksen's collapse. You also know another player, and this is all data, obviously, that's online. I'm not chatting here out confidential data, but the Luton player who had a cardiac arrest on field as well. Then there was another one, and which I will show you in the video. Bas Dost in a Dutch league.
Senden uzun toplar gelmeye devam ediyor. Bu arada Bas Dost bıraktı kendini yere. Cassius getirdi topu. Cassius ceza sahasında penaltı bekliyor. Ağzı akmalı futbolcular bu arada oyunu durdurdu karşılaşma.
And two players. Immediately someone was there, was starting resuscitation, and Bas Dost is now well, he survived, because the awareness of secondary prevention is there, and this is probably the biggest thing as well. But then there are also other cases. So this is Saliterna in the second league. You will see on the left-hand side of the picture in the red left, red jersey, 1, 2, 3, come. This Patrick Zizek. He collapsed as well. So, 4 cases, quite clear, all sudden cardiac arrest. Really? First thing. What do the guidelines say here? I can use now a couple of guidelines. I can firstly, what guidelines do I need? I need guidelines to say, have I screened them? And they were all screened. They were all screened, many of them every year, every second year, all these cases, and they were in the last 2 years. So, have they all been screened? Did we follow screening guidelines? Yes. What are the guidelines now? What diagnosis do they have? Can they return to sports? I need to find a guideline. I also need to find a guideline to say, do they need an intracardiac defibrillator? Another guideline. There are 4 clear cardiac arrests. All have an arrhythmia, all have VF probably, so. But what do we do with them? How do we get them back? Because there are individual stories behind them. And as you know, two of those are playing again, and I'm looking after them. So, and my opinion is that one of them is probably not a cardiac arrest. How do we figure this out? There's no guideline. There's no guideline that will inform me to an extent to make a decision there. So how do I make a decision? Of course, I can say, well, look, these are the guidelines. Let's stay conservative. Your career is over. And this has been the case for many years. And it is still the case. And I would not criticize these colleagues who do this because they are guidelines. And as you know, in Italy, there's even a law. So it's very difficult. Yeah? But particularly the Patrick Zizek now, he was 18 months out of competition. He came to us in Aspetar, and he's playing now for the last 2 years again in Poland, and is really knocking at the door of the Polish national team. So would I have done right to this player if I'd just followed guidelines? And if I don't follow the guidelines, because they would have said until now, most of these players should not play. So what else do I have to base my opinion on, apart from being a brazen and overconfident cardiologist and say that's all tosh and I do it my way, which I'm not doing. Yeah. So this is very important. So what are the real limitations of these guidelines? The first limitations, they are methodologies, and that's why I put this slide on. That's very easy, okay? The guidelines often don't account to the population. So we've done a lot of studies where we took cardiomyopathy guidelines for adults, and we applied them to 17-year-old, 16-year-old athletes. And 7% of our footballers, academy footballers, would have fulfilled the criteria to have a left-sided cardiomyopathy. And 15% would have fulfilled the imaging criteria of having a right-sided cardiomyopathy. The right-sided cardiomyopathy, the incidence is 1 in 3,000. Come on, that cannot be true. Yeah? But we are stuck here. There is, even in my automated echo analysis, it comes a light up, says red flag. This is a dilated right ventricle. The guidelines say this might be beginning cardiomyopathy. Will I even tell this athlete this? I cannot, because if I put out cardiomyopathy to an athlete, this is the big thing, not only for him, for the club, for the family, for everyone. So what is my next step? What do I do? And here, I have to say we have a tool that goes beyond guidelines, and this is really having an expert committee. Yeah? And that it works, the best proof is the World Cup, and of course compliment also here to Aspetar, to us, because we created an environment that these players could actually and can actually play and could play safely. But don't forget, Christian Eriksen and Daley Blind were the players first time ever who played with an ICD at a major tournament without any problems. So, question, did they do this because they had annual good screening according to the guidelines and they were fine? Of course not. Even for my peace of mind and for my colleagues' peace of mind who look after them, there's more to it. And that's what I want to come at. So sports cardiology, screening is a very basic part, but we have to decide if we as a sports community, and I think yes, we want these players with heart disease, any heart disease, to play, we have to do more than just annual screening. Particularly these two, I mean, as you know, Christian has been looked after by myself and also by Harald Jostad. We have a team for the last 2 years, but it was not just we screen him once a year. There's a lot of monitoring, there's a lot of technology going on, and there's a lot of communication on with these players. So this is really, really beyond screening. And the guidelines starting to say now, well, we should have a patient-centered approach. But for us as cardiologists, there's no guidance how to do this. What are the red flags? What should we do in terms of in-season medication, all these things. So these are very, very important questions, and I'm glad that we are now pushing the boundaries there, and obviously the players I think, are very grateful. And of course, it has to stay within the realm of safety, which we are doing. Yeah. So how can we do this? How can we do such thing? Well, firstly, as I said already, of course, if you want to do it, you need to have a top service. And this top service we did have here, and we mustn't forget it. There are not hundreds of centers like Aspetar, and there are not 100 fantastic sports cardiology groups, starting from the nurses, physiologists to the doctors, who can really embrace this and provide this care. Because if one little wheel doesn't run smoothly in this, then it's not possible. I cannot have a player, with cardiac disease playing that I see once a year and do an ECG. I mean, that will not happen. We need more. So of course we need these institutions, but what is most important is really we need the experts. We need an MD. We need an MDT. There's rarely a decision at this level that is being done by one cardiologist. I do believe that there has to be a core sports cardiologist in all these scenarios for the players. But this is an MDT. And Harald Jorstad, who also advised us during the World Cup, and I work very closely together in Amsterdam, has in fact published a paper. They've published a paper on their multidisciplinary team meeting, how it works. And I'm part of this multidisciplinary team as well. So we meet every 2 weeks. I haven't got always time to be there. And look what we have here. I mean, they're not only sports cardiologists. They're clinicians. They're from all specialties, even geneticists. Yeah. Sometimes for individuals, even psychologists. And this seems to work. And I will show you figures, and you can decide if it works. So you discuss it. And what is the importance of this MDT? Is it that all these guys who sit there, the sports cardiologists, the geneticists, and so on, is it that I go there because these guys know the guidelines and show them to me? Not. I go there and because there are people with expertise there. There are people who've seen these cases, and even Sina and Razi out there, they will be smiling now, because that's what our teachers and forefathers said exactly. Acribic discussion and documentation of cases. That's what medicine is also about. So I'm at these MDTs because I've got a geneticist who's a world-class expert, and he gives me a little bit of information that will help me to make sense of the case. So what happens in these MDTs? That's also interesting. So before the MDT, of all these athletes, however these were, this is just a small number, 22 had no restrictions. This went interestingly down. Yeah, and this is for me also a question. So you had no restrictions, 22, but many of them were restricted to just no peak exercise. This is debatable if it's right or not, and I don't always agree, but there was a big change. There's also a change from total restriction to allowing these athletes to do some exercise. And there was also some where we said, look, they shouldn't do too much, and actually in the end, after an MDT, they said they had no restrictions. So this is clearly shows that such an MDT with expert opinion can have a really, really important decision on the athlete's career. It is for me very interesting that many of these MDTs, this is a very good one, and Amsterdam is fantastic. It's a joy to be there because of the expertise. But often if you bring in experts, they might not have expertise in sports cardiology. And again, this usually leads to more conservative assessments. And again, this is also difficult. If you've got an expert in genetics who doesn't really know about athletics, he might be conservative and not grasp the whole picture. So we need to educate also the people in these MDTs in sports cardiology. What is even more striking is this, and I'm really pushing it to say, okay, good, guidelines, then we have MDTs, at least you get a balanced view. This is a paper from Michael Ackerman's group in the United States. And Michael Ackerman is a really world expert in inherited disease and sports cardiology. And what he has done is, even I get a little bit nervous and a bit high blood pressure when I read these diagnoses. So he has a lot of athletes he lets play, of course, under expert follow-up. Some even with CPVT, which is catecholaminergic polymorphic ventricular tachycardia. You don't see anything on ECG, you don't see anything on echo. It's inherited. They have genetic mutations, and the first presentation is a sudden cardiac arrest in over 50% of cases. This is for most of us. No, he lets them play. And if you look at the event rate, this is unexpected cardiac events from these ones who are active over a 10-year period. They don't have any events. Wow, this is fantastic. No guideline will support this. And I know Michael Ackerman has we discussed it. This is difficult for him because he goes beyond it. But with expertise, with MDT, he can do this. And I think he's doing it right, and he really serves these athletes well. Yeah. So this is very important. Interesting enough, look at the figure down there. Even if us sports cardiologists are really progressive and do something to the best of our knowledge, just because of the inherent culture of sudden cardiac arrest, 20% of his athletes were still barred from competing because they had a background heart disease, and organizations were not happy with this. I'm not saying it's completely wrong. It just says also we have to discuss with organizations what is a consensus here in the best interest of the patient. But even cleared patients, 20% of cleared patients with cardiac disease were not allowed to do sports. That's not quite right. So there's still a lot of work to do. One more example, and then I want to show you actually an interview with one of the athletes for the next 5-6 minutes. This is an athlete who had a cardiac arrest with ventricular fibrillation, as you can see it. So fantastic secondary prevention is really working. Bystander CPR, really amazing. Survived all well, had all sorts of tests. Not much was found, but probably ischemia, like a normal heart attack. And a 35-year-old is rare. They couldn't see very much, but we concluded there must have been an embolus who blocked the coronary artery. So now then I come in and say, okay, great, let's go. We have guidelines. So firstly, sudden cardiac arrest. Okay, you've got an athlete with sudden cardiac arrest. You look at the diagnosis. Diagnosis is ischemic heart disease. Ischemic heart disease is a reversible event. First thing is, well, he should be able to go back to play, unless he's got a lot of coronary artery disease, which he didn't have. Next question is, he didn't have anything at all. Does he need a medication? And the next other question is, does he need an ICD? The guidelines at the moment say, and this is here also, and I want to show you this because of culture in cardiology. In the 90s, people with ischemic heart disease, when they had a cardiac arrest, like a heart attack, but you have actually a proven abnormal rhythm, ventricular fibrillation, not many of them had an ICD implanted to prevent another arrhythmias. But look at this, in 2000, 60%. Now it's gone down, and now it's actually gone down even further. So, and this is really on a bit more data, but it's also a cultural change because we are really worried about these people here. So we said, okay, an ICD will help. So we put ICDs in. But this study shows actually, if you put an ICD in, the cardiac mortality is actually higher than if you don't put an ICD in. Of course, there are many reasons. Firstly, because if you get an ICD, you may be sicker and so on. Yeah? But an ICD doesn't help. But then again, my sports cardiology guidelines say, well, hang on, if you've got someone with a proven ventricular fibrillation, unless there's a clear cause that is reversible, they need an ICD. So, does he need an ICD? Because I know if he gets an ICD, there will be some countries where he will not be allowed to play. This should not be a decision I make on this fact, but it's important. Of course, interesting enough, then this athlete, not this one, but other athletes have come to me and say, oh, well, hang on, I know footballers who play with an ICD. Can you just not put one in so I can play? My guidelines say this is not an indication, and I agree, for an ICD just to let him play. So what you do with this player? Can he play? Should he have an ICD? What medication should he have? Which category does he fit in? Because now we're going from the sports cardiology guidelines to cardiology patient guidelines, which in ischemic heart disease have little to do with our athletes. There's a completely different group. They have different comorbidities. Again, I've got not much to go by. So I do an MDT and can help these athletes to do what is in their best interest, but of course what is medically also safe. So how I think we do this is, we have these guidelines, we know our guidelines, we have the base, but sports cardiology at the moment, if you want to do it well, in my opinion, goes far beyond it. So last bit is really another 7-8 minutes. Okay, we still have guidelines. It's very tricky to work with them, but can we actually, because that's a big word now, individualized care. And I hope I could show you that, or at least invite you to the thought that sports cardiology at the moment, particularly with athletes who have heart disease, is individualized care. You really need to spend attention on these from very different angles and accompany them, follow them up. So can we do an individualized guideline? Very difficult, because guidelines are made usually with the core of there's a diagnosis, there's a clinical problem, this is the diagnosis. Now I go and either do this or do this depending on various clinical facts. Individualist guideline would be very different. And I got together, and there's one part of heart disease which is congenital heart disease, and that's what I trained in, which lends itself to it, because congenital heart disease, these are, you will have learned it, these are these children who are born either with the arteries, mixed up, so they've got the pulmonary artery, which I will show you in a second, pulmonary artery coming from the left ventricle, the aorta coming from the right ventricle. They've got the atria switched around. They've got holes in the heart. They've got sometimes only 2 ventricles. So it says congenital heart disease, but it's 30 diagnoses. So I got together with a colleague of mine, Werner Butz, and we said, okay, let's make an individualist guideline, and we forget completely the diagnosis. We take this big fact that puts people into categories out completely. And what we do, you just need to look at the black and then the left. We just go by physiology. We say, I don't care if this person has a diagnosis of tetralogy, of Fallot, you might have heard of this, or transposition of the great arteries. What do I need to look at if it comes to sports and exercise? What do I want? I want good heart function. So we look at the ventricles. I want the pressures in the lungs to be low, because that is not good for you. Of course, I don't want them to have any arrhythmias, and I want the aorta to be of a decent size, and I want to see how they do at exercise. And we don't care what diagnosis they have. And we've done this actually, and this has been published in 2020, and this works actually surprisingly well. And it's a very basic stuff, and the most important thing is really history and physical examination. The basic skills of us doctors, you assess these parameters, and here you can go wild. You can do an MRI scan, you can do whatever you want. You do all this, and then you assess them with exercise. And of course, very important, you discuss it with the athletes' wishes. And I want to show you one successful example who's a patient of mine, and I'm going to show you the interview with him, who I had the really honor and privilege to follow up since he was a small child. He was first followed up when he was born by my mentor, Professor Graham Stewart, who was the first pediatric sports cardiologist. This young man is now 19. He was born with transposition of the great arteries. And I remind you what it is in a second. But what we did with him, he was a very talented 800-meter runner. But because of this assessment, because of following this individualized guideline, we told him early at some stage, look, mate, you're very talented in sports, whatever you do, but 800 meters with transposition of the great artery, he also had some leakage in his valve. You can do it. I support you. But you want to become GB champion? Yes. Then maybe it's not the right sport. So we put him down from all sports to skill sport. Well, or mixed power sports. So, and before I show you his case, I want to show you that's transposition of the great artery. So you can see here, this is the right ventricle. Normally, the right ventricle, the blood goes into the pulmonary artery, goes into the lungs, takes up oxygen, goes into the left ventricle and goes out. What happens in these babies is the right ventricle, the blood low in oxygen, goes into the aorta, goes back into the body, goes around, goes back into the right heart, goes back into the body, and the blood in the left side goes from the left ventricle into the lungs, take up oxygen, goes back to the left ventricle, goes back into the lungs. So they've got no exchange, no oxygenation, no exchange of oxygenated blood. It's 2 parallel circuits. These babies are very sick when they're born. They are a huge challenge for pediatric cardiologists. You know, we need to do maneuvers. We sometimes put a hole into the atria to have some blood mixing. And the mortality until the 80s was 50%, 40% in the first 5 years. I mean, credit to our surgeons. They all now 95% survive into adulthood. Yeah? And our young athlete is one of those. Yeah? And here you can see 2 generations. On the left, ortho patient of ours, he does not have exactly the same disease, but he has complex congenital heart disease and is a bit older, which was palliated before. And you can see this young gentleman, he's competing as well, but he's competing against fatigue and deterioration. And you can decide who's braver. You know, I think this is extremely brave. You can see also their clubbing in his fingers, their cyanosis, there's a wheelchair. He cannot even go to the gym, but he does his training. And on the other hand, we have Luke Ball, who's competing at the World Championships with the same diagnosis, with a transposition of the great arteries. And he came in 5th or 6th with 2m12, and he's a current Great Britain under-20 champion. Are we crazy to let him do this? No, but when he was very young, he got the right advice, and he got a lot of support. Also, the family at the Bristol Heart Institute with really doing super modern care, really letting him do these things, and making sure the physiology is fine. But as you will hear in the interview, also making sure that his confidence, his drive, everything is aligned, and he is not this kid with severe congenital heart disease, but he is Luke who wants to become a good high jumper. Yeah? And I think this is very important, so I'll let the video play. And now it's only 6 minutes. It's an interview, and I'm very grateful, and of course he consented to Luke and also his mom to really give some insight what it is for a top athlete to have a significant congenital heart disease. Yeah? And I think it's quite insightful. Hopefully you can bear with me. The interviewer is a bit jet-lagged in Malaysia, so I'm sorry. There's a lot of eye blinking going on. I hope you will forgive me. Okay. Another thing I want to say, of course, is, if you want to do modern sports cardiology, you also need to have the right tools. So exercise imaging, which we are now doing here a lot, is an important part to assess these athletes, such as Luke, during exercise. So that's very important. Okay, let's play the interview. So hello everyone, we've got Luke Ball here. It's a great honor to have him with us for this short video. He's the under-20 GB high jump champion with a PB of 2:14. And Luke, as you've just heard, has been operated with transposition of the great arteries in childhood. Hello, Luke, welcome.
Hello.
How are you? You're well?
Yes, I'm all good. Looking forward to it.
Fantastic. So let's go right into the matter because we don't have too much time. So the most important question I want to ask you, I mean, you're an elite athlete, you're a pro, you're a GB champion, which is fantastic for anyone, but you have had major heart surgery in childhood. And we are all asking ourselves, has this had an impact on your athletic career? Do you think it's had a negative impact, or was it even a special motivation to have heart disease and be such a talented and high-achieving athlete?
Yeah, well, I've always loved sport, really. Family loves sport, so I've kind of grown up on it, especially football as well. But yeah, managed to get into athletics, and how it's impacted me. Well, I think I've chosen a good sport because it's high jump's quite a short, powerful event rather than a long endurance, which I think may have proven a bit more difficult. One important thing I would say is that I've always been told there is no restriction on activity, so it means a lot that even with the heart condition, I managed to keep going and competing in sport and now reach a pretty high level.
Fantastic, well done. And I wonder, when you warm up for a competition, do you ever think of having had heart surgery? Do you ever think of, oh, might something happen with me or not? Tell me.
Honestly, no. It never really crosses my mind, to be honest, because it doesn't impact me. I don't feel any repercussions during a competition or for when I'm warming up. Normally, if I'm away with a GB team or an England team, I'd have to let the team doctor know and just talk it over with him quickly. But no, it doesn't impact me at all.
Excellent. That brings me to my next question. You talked about your Team GB medical doctors and teams, and I know, of course, many medical teams and doctors who work in high profile athletes, and they're usually extremely good and they take good care of their athletes. Did it sometimes take some convincing for them to actually let you do everything you want to do, or were they supportive?
Actually, no, very, very supportive, because I've had good advice from cardiologists like yourself to be able to compete. That's fine. The team doctors just want to be aware of it and then support me in the process.
Excellent, thank you. And we have also Luke's mum, Liz, here on the call, as you can see in the video, and I will ask her in a second, but I want to know from you, Luke, how has your mum always supported you? Because what we find as doctors is that parents are, rightly so, often very cautious because they're worried about you. They've seen you as a little baby having had heart surgery. So how was it with your mum? Did you have to sometimes run away to training, or was she always supportive?
Actually, very supportive all the way through. Driving me back and forth to training, competitions up and down the country and things. Very supportive. Partly because we've had the advice from the specialist that you're okay to exercise. There's no restriction, and that led to my mum and dad being more confident and giving me their full support, which is brilliant.
Fantastic, Luke. We will. You will have the last word. Don't worry. But I would love to bring in your mum, Liz, and I would like to ask Liz as well. Liz, what is your side of the story? Were you never worried? Would you have liked to have had more advice from us doctors, or did you feel sometimes left a little bit alone, or could you always full-heartedly say, "We know everything is all right. Let him do his sports"?
I think the honest truth is we're always worried as parents, of a child with a heart condition. It's always something that's on your mind, which you obviously try not to impose that on the young person themselves. But we were told from the beginning to not treat Luke any differently, to treat him as normal. But then still, when he's busy playing football or doing cross country or, you know, riding his bike, you're still worried, should he be doing that? Is it okay, or is it too much for him? And that's where I think having the support and the advice from your team is really important, and knowing someone's there at the end of the phone, that, you know, they might only take 5 minutes out of their day, but it can be a lifesaver for a parent just to be able to get on the phone and chat to someone through some of those concerns and get some reassurance. And I think what we crave as parents is that specific advice for our own child, for our own individual situation, because there is information out there, but it's not necessarily about my child and what my child can do. But we did find, you know, particularly as Luke progressed in his athletic career, that we got much more specialist advice going forward, which has been really helpful. And obviously, you know, people do keep a very close eye on how he's getting on.
Excellent. Thanks very much. That was really insightful. And I have to say, you were also parents that were always interested, were always on the ball, and really looked for this information. Sometimes we struggle because not all parents are like this. So a big compliment back to you as well. So, Luke, last words to you in this short interview. I want to know, what advice would you give younger children who have been operated with heart disease if they want to do sports? What would you say, as someone who has really pushed it forward in his career to a national and international level?
Yeah, I think the first thing I'd probably say is take the advice of the doctors and the cardiologists, because I think they probably know quite a bit more than I would. But let's assume, you know, there's not really any restrictions on the exercise they can do. I would say go out and try loads of different sports, whether that's in school, out of school clubs. Doesn't have to be competitive either. Go for a run with your friends, go to the gym, just anything. You will find something that you enjoy and are good at. Another thing I would quickly say is that actually taking part in sport, I've been told by doctors, has actually helped me slow the deterioration of the heart condition, because I'm quite physically fit, as well as a big factor of taking part in sport is the mental health side. Feel good, make friends, you know, football team, athletic squad, you make a lot of friends, and that's a big bonus. So definitely, if you can, please do some exercise in sport.
Okay, thank you very much. That's it. Of course, you know, there were some things in the script. You know, he had to say, I listened to my cardiologist. He had to say, you provide excellent care, but you know this, okay? So I want to conclude, but before this, I want to say also, there are a lot of interesting facts and so on in this interview with an athlete, but to our topic, what is important is that Luke's mom says there's a lot of information out there, which is true. I mean, if you look at it, if you want to know about transposition of the Great Heart Race, parents go online, and there are many also very good websites and so on, but she said, but we want something that is specifically for my individual child. And you will not find this online. You cannot, even if you have the best leaflets, the best websites and so on. And this was an important point I wanted to make. And that's why parents with children, but also athletes, come to our specialists. Because they've read it, they've known it, they even had advice, but they want this very individualized, tailored advice. And that's very important. Yeah? So my take on all this is guidelines, of course, they provide guidance, but they don't guarantee excellence in care. And I'm adamant that will not change. That will not change. We need to know them, but we need to be beyond it if we want to do care. But they're also not the enemies of individualized care. On the contrary, they're the base. And this is very important as well, because there seem to be more and more two camps here. You know, one is pro-guideline, the other one is pro-individualized care. This has to go together. Yeah? And if you want to build excellence, you need to know the guidelines. We need good guidelines. And, you know, I'm clearly pro, otherwise I wouldn't chair 3 guidelines this year. So it is very important, but it would be an illusion to say that we are good doctors if we just follow these guidelines. Yeah. And in my eyes, I think really a team of guided experts, of course, with the athletes in the center and so on, they would provide the best care. Yeah. But very importantly, it needs to be embedded in the infrastructure. And this is compliment and to Aspetar here, because we have this here, but also like a call, we need to continue to do this, to provide this cocoon for experts, and we all are these experts, to work here with our patients. And the other thing is, which might a bit soft and touchy-feely, but I think particularly working with athletes who had sudden cardiac arrests, I mean, a life-changing event. We are part as health professionals, and not only doctors, particularly more so as physiotherapists, nurses, because you're in many ways much closer for much longer with the patient. We are part of their health biography, and we need to be aware of it. We can help to shape this in a positive way, not to just treat them and let them go away, but really accompany them. And I realize more and more, I'm asked to do this. I'm not asked to just do the ECG and echo from these athletes and then tell them bye-bye. They want information. They want more. They want even predictions, and they want to feel that I'm there and part of it. So that's it. I've got one more little lighter note I want to tell you, but first of all, thank you to everyone at Aspetar. I think all our services, be it surgery, be it rehab, be it anything, cardiology, is working here because we are a team that seems to pull on the same rope, which is fantastic. And when I get patients from other departments coming to us, 99% of time they are happy. They're happy patients coming from you guys, and that is good. That gives me a good feeling. Okay. The other thing might take a lighter note on guideline. With guidelines, for me, it's like this. For me, it's like with football allegiance. Okay, you have to have some allegiances. You have to be seen to, be there. Have an allegiance with your team, because in Germany, because I was born there, and so on. And the same with guidelines. You need to take them into account. You need to be seen to say, I use them. But in the end, particularly as a sports cardiologist, you need to know exactly where your heart is. Okay, and that's how I want to finish. Thank you very much.